Okay, I'll discuss today's file. 1 minute. Okay. How many doctors? Okay, 10 doctors. So now let's start. Okay, today our first question. Okay, first question is a patient scheduled to undergo varicose vein surgery in 3 weeks. He has been taken clopidogrel for coronary stenting done 4 months ago. Next step. We have discussed like these kind of questions, right? I think in November and October as well, but I'm not sure about the month. But you know the answer. Type in the chat. It's a easy question. What do you think? What about other doctors? Hurry up. Mm-hmm. Okay, so tell me how long we should give uh, this antiplatelet therapy after stent. At least how long we should give. Yeah, the usual 12 months. At least we have to continue till it's 6 months, right? And we have two types, right? Bare metal stent and drug-eluting stent. And for those, usually they have a different time period as well. Yeah, at least 6 months, remember. Okay. So let's little bit discuss here. This is from RSHGP guideline, perioperative period. Here, yeah, recommended that elective non-cardiac surgery should be deferred for at least 6 weeks and ideally 3 months following PCI with BMS. BMS mean what? BMS mean what, doctors? I just told you. Tell me BMS what? Bare metal stent, right? Bare metal stent. And for this one, yeah, bare metal stent, it's usually 3 months is enough. But for the drug-eluting stent, it should be 12 months following PCI with drug-eluting stent, right? Due to high risk of death and myocardial infarction and in-stent thrombosis. Here, so let's clarify about our patient. The patient had a coronary stent 4 months ago. Okay, the planned operation is varicose vein. It is a elective one, right? Elective. So not a urgent one. Urgent surgery. Minute. Then, after coronary stenting, platelet can easily form clots inside the stent, right? Because it's a new thing, right? Something new inside our body, right? Then our own body try to attack it, right? By making platelets, they feel like it's a foreign body, so they try to attack and make clots. Then clopidogrel prevents stent thrombosis, which can cause acute MI, sudden death. And the risk of stent thrombosis is highest in the first 6 months after stent insertion. So stopping clopidogrel at 4 months is not safe, right? So continue clopidogrel and also increase the surgical bleeding risk, right? So stopping clopidogrel much higher risk because stent thrombosis is a life-threatening event. So we have to control these two, bleeding risk and thrombosis risk. So better this is a varicose vein surgery. We can postpone the surgery because it's a non-emergent surgery. So in that case, best one is reassess the need of surgery, right? So better to go with that part. So you all. Okay, there's a question. A 68-year-old woman present to the pre-admission clinic for an elective total knee replacement scheduled for next week. 3 months ago, she had a anterior T-segment elevation acute coronary syndrome due to left anterior descending artery disease and underwent PCI with drug-eluting stent. Since then, they said that in urgent surgery, uh, wait, doctor, I have to find it out a proper guideline. Usually, in urgent surgery also, as I remember, give me 1 minute. We have discussed that part, but currently I can't remember it properly. So give me 1 minute. I'll tell that part as well. As I remember, we have to stop the clopidogrel and continue aspirin during the surgery, as I remember correctly. But I have to first make sure and then I will tell you, okay? Because it's a recall class, right? Your exam is in near a month, so I don't want to tell anything without any proof right now. So here, yeah, then intervention with the drug-eluting stent. Since then she has made a good functional recovery and has no current chest pain or dyspnea. Her medical history include hypertension and hypercholesterolemia. Her regular medications are aspirin, ticagrelol, atorvastatin, and perindopril. She does not use tobacco or alcohol on examination. She appears well. Her pulse rate is 72, blood pressure 128 by 78, respiratory rate 14, SpO2 98. And here, electrocardiogram today shows a sinus rhythm without acute ischemia changes. Blood tests are within uh, reference limit. Which one of the following is most appropriate next step in management? What do you think, doctors? Okay, let's check your answer here. So defer surgery by at least 3 months while patient already had PCI with drug-eluting stent, right? So perioperative planning after recent coronary stent insertion for acute coronary syndrome require balancing bleeding risk if dual antiplatelet therapies continued against stent thrombosis is risk if is interrupted. The patient had a left anterior descending artery disease, which carries a higher risk of recurrent ischemia. In this setting, guideline recommends 6 to 12 months of dual antiplatelet therapy. So, stopping P2Y12 inhibitor prematurely substantially increases stent thrombosis and myocardial infarction risk. For elective procedures that typically require interrupting antiplatelets, deferred surgery is preferred. Okay, let's proceed surgery and continue dual and plate therapy is inappropriate as a major joint arthroplasty. And continue. No, they haven't mentioned proceed surgery. The duration of DAPT after DAPT, mean dual antiplatelet therapy after undergoing revascularization for ACS depend on both ischemic and bleeding risk. So we have to think about thrombosis risk and bleeding risk. So stopping dual antiplatelet therapy prematurely carries a high risk of stent thrombosis and MI. So platelet coagulation factor products do not reliably reverse the antiplatelet effect and do not substitute the appropriate surgical time. Okay, so I will find that and I will attach doctor. Otherwise, it will take time. I will do it during the break. Okay, I have a note, so don't worry. It's not take much time about the urgent surgery. So the next question. So the next one, 48-year-old healthy woman. 48-year-old healthy woman attend for preventive health advice. Her mother developed osteoporosis at 56 and breast cancer at 65 years of age. Her grandfather developed colorectal cancer at 70 years. So, what do you think? I haven't add the references. We have discussed this part, right? So, what do you think? So, tell me different. 1 minute. Yeah, tell me your answer. What do you think? First, you answer, then we will discuss. Okay, so let's check. 1 minute. I have to find out. It's easy when I can. I had to buy the 100 GB for yesterday. I have subscribed for the more storage. Wait 1 minute. Okay, so tell me about. Okay, let's discuss one by one. Okay, so what about the this one? What about the colorectal cancer? Cancer is. I will add this reference. Okay, so don't worry. So our patient is 48 healthy woman and her grandfather. Grandfather means second degree relative. Colorectal cancer at 70. So that's mean in which category? Here, no family history of colorectal cancer or one first degree relative diagnosed at age of 60 or older. So our patient is having the second degree one, so it can be average risk right here. Okay, so average risk people screening with FOBT every 2 years, right? Starting from 45 years. Okay, that's a 1 point. Our patient is 48. Okay, we can consider this one as well. Then, next, let's go through the breast cancer first. So, what about breast cancer here? Our patients, our patients who mother develop breast cancer at 65. So, that means which risk? Which risk, doctors? One first degree relative diagnosed with breast cancer at age equal or more than 50. So it also average risk, right? So average risk people, what we should do, women at average risk or slightly higher than average risk breast cancer should participate in mammographic screening from age 50 to 74. So starting from 50, right? starting from 50. Mhm. So let's go back to our question here. Mammography starting from 50, earlier if higher. So this also makes sense. Okay, so we have two options. Then the next option is what? Next option is, in this case, they have mentioned about osteoporosis at 56. So, osteoporosis doesn't have any proper screening protocol, but we have this one. Okay, we have this risk factors with no fractures. In here, we have already discussed our patient is anyway not more than 70, no any fractures, and they haven't mentioned anything about this lifestyle fracture lifestyle problems like falls, poor balance, low physical activity, immobility, low muscle mass. Okay, there's no. But we have only the only thing we have is mother who diagnosed osteoporosis at age 56. So that doesn't make any sense, right? That doesn't make, at least even though our patient is having these risk factors like celiac, rheumatoid arthritis, early menopause, hypogonadism, hypothyroidism. So then we can think about some risk factors, or patient is using glucocorticoids like more than 4 months with daily dose of 7.5 milligram. So it's also a risk factor, and exceed thyroid hormone replacement, androgen deprivation therapy, so aromatase inhibitor. So these are the risk factors that we can think when we think about the screening for the osteoporosis. But there's no specific protocols like colorectal cancer, breast cancer, and if the patient is having these factors, we can use the frax calculator. And if patient is having these factors, we can do the DEXA scan. So this is, but that doesn't make sense in our case, right? Yeah, then let's go to our question. Our patient is 48, right? Mother developed osteoporosis 56 and breast cancer. So what we should do is A or B. So what do you think? What we should go with? A or B? What do you think, doctors? Mhm. Then what do you think? Okay, bone scan out, colonoscopy out. So what about fasting blood sugar? Is there any routine screen? Because our patient is they haven't mentioned anything, patient's obese, or patient is having any like any diabetic related problems, or no obesity. There's no risk factors, right? So they are asking like a better option. So we got two options, A and B. So I think better we can go with fecal occult FOBT, right? Because it can start from 45. It is the earliest one we can do now, right? Because already patient is in 48, so we can just do the FOBT for this patient, right? And mammography, for the mammography, we can wait till 50, right? According to the national protocol. There's no protocol, doctor, for the fasting blood sugar. So opportunistically, we do screening. There's no specific protocol for the fasting blood sugar. Okay, so yeah, I think better to go with A, fecal octal blood test because it started from 45, right? So now we can do that FOBT test because our patient is 48, right? 1 minute. Not this one. Here, asymptomatic adults age 45 to 74, FOBT 2 yearly. So our patient is 48, so better to go with that. So what do you think? You agree or not? That's the best thing, right? If the age was 50, then how will go with first mammography? Hmm, I don't think they will give those kinds of questions, doctor. Like in here, they have given this one because they are starting from 45. So best we can go with this. But if the patient is 50, like I don't think they will give both in one scenario like this because we have see some questions, right? They are not confusing us like that, right? Do you remember we have done those questions? Then there is still 1 minute. The color has changed because in that case, if the patient is 50, we have to do both, right? Because 1 minute. Because FOBT should be start at 45. So patient is already 50 mean we have to do FOBT, and if the patient is having the average risk of breast cancer also we have to do the mammography from age 50 as well. Then these two answers should be in one category, okay? So better to like go with the both answers because both are correct in age 50, right? Yeah. Yes. I'll add that the same references from our November file, right? Yeah. The next one, a patient with end-stage cancer has severe pain. She's currently taking oral morphine 20 to 40 milligram twice a daily and experience intermittent drowsiness. What should be added to her treatment? So, what do you think? What do you think, doctors? Type your answers in the chat. Mm-hmm. So, what do you know about the uh, pain management in palliative care? What do you know about? Okay, let's little bit discuss about it. Role of opioid in pain in palliative care. For patients with palliative care needs who are in last year of life, opioid therapy usually provide the best relief of moderate to severe pain or pain that does not respond to other measures. Here, opioid have a role of management, background pain, breakthrough pain, and incident pain. The role of opioid therapy is multimodal analgesia described. Yeah. Then starting opioid for pain in palliative care. The treatment approach to start opioid therapy for pain in patient in palliative care need to start an immediate release opioid to be taken as required intermittent pain. This approach test patients' tolerability to the opioid and inform the ongoing optimal dose and regime. So, what we should do first, we have to start the immediate release opioid, right? Immediate release opioid, because we have to check the patient's tolerability, right? Tolerability to optimal dose and regime. However, it should not be used as the initial strategy in setting where the timely administration of as required opioid may be challenging. Example as residential aged care facilities. An alternative approach to start regular opioid therapy, either oral opioid, transdermal buprenorphine, together with immediate release can take as required. I'll discuss, okay? We have everything here. Then, starting opioid therapy is a signal to review the effectiveness and burden of the analgesic, particularly paracetamol. Then what else? Okay, choice of opioid for pain in palliative care. Although the morphine and oxycodone are preferred opioid for pain management in palliative care. Opioid choice depend on the general factors guiding analgesic choice and prescribing consideration. So what are those? Yeah. No, I haven't had that part, so that not on here. Transdermal opioid formulations. Buprenorphine or for the patient stabilized on oral opioid dose equivalent to oral morphine 30 milligrams per 24 hours or more fentanyl. Okay, these buprenorphine or fentanyl we can use as a transdermal opioid formulation. When who? Patient who cannot swallow, having impaired GI absorption, would have trouble adhering to the frequent administration of the oral regime or preferred non-oral options like example for cultural or psychological reason. Although hydromorphine or methadone are used in palliative care, their prescription should be limited to the healthcare professional experience in their use. Something else. Yeah. And for initial requirement therapy with immediate release opioid for intermittent pain in the patient with palliative care need who do not already take regular opioid therapy or just start in regular opioid therapy, right? So here, morphine immediate release 2 to 5 milligram orally, 1 hourly as required we can give. For patients who are older, frail or chaotic, use the lower end of the dose range and consider more prolonged interval between doses. And we have to monitor the response and review therapy if 3 or more doses are needed within 24 hours. Then what about oxycodone? Immediate release 1 to 3 milligram. Okay, remember here 1 to 2 milligram. 1 to 3 milligram in morphine, 2 to 5 milligram. Here also 1 hour required as required. So the same thing. Yeah. Yeah, here again, here they have mentioned who can't tolerate oral therapy or who can't be adherent to the therapy or within GI problems or everything. We can think about transdermal. Same thing here. The principles of switching from oral opioid to transdermal fentanyl in palliative care. Establish the total amount of oral opioid take in previous 24 hours. I'm just reading because sometimes they can ask from these things as well, because they have asked that question, that mean in the future they can ask something related to here. So principles of switching. First, we had established the total amount of oral opioid taken in the previous 24 hours, then include regular dose and dose taken for breakthrough pain. Do not include dose taken for incident pain. And we have to calculate the equivalent dose of transdermal fentanyl patch. So you remember we have to give equivalent dose, right? That's what we are calculating the previous opioid dose. Okay, that's the main reason we are calculating it, because patient is stable on that dose, so we have to give the same dose here. Then tablets given suggest a starting dose in the fentanyl patch or fentanyl patch product information. Then equal analgesic dose given in if the oral opioid dose equivalent to oral morphine 90 milligram or less daily. Yeah, so this is how you can give it a rate. They calculate this morphine, original morphine dose, then how to calculate for transdermal fentanyl care. So you can give it a rate. It's not very important, but I have add because who know, right? In the future, they can ask something from here as well. And so, what are the regular transdermal opioids for background pain in palliative care? So here we can give fentanyl, transdermal patch or buprenorphine. So these tools for fentanyl can be considered for patients who have persistent pain and stabilized on oral opioid dose equivalent to oral morphine 30 milligrams per 24 hours or more. For advice on switching to transdermal fentanyl opioid, yeah, we just read that part. That exercise caution when considering a dose increase of transdermal fentanyl. Wait until 3 days after the patch was applied before assessing the effectiveness. Okay, so that's a good point. A small number of patients find the analgesic effect of the transdermal fentanyl patch wears off easily, so necessitating a change of patch every second day rather than every third day. Yeah, so that's all for the fentanyl transdermal patch. So in that case, what do you think? Patient with end stage cancer and severe pain and oral morphine, and patient is uh having drowsiness, right? Having sedation. So what should be added to her treatment? So what do you think? So we should not increase the morphine dose. So best thing we can add the fentanyl, right? Right? Okay. So I don't know what are the other options, but hopefully that will be so. Okay, so next question. A female university student does not want to become pregnant during her studies and reports irregular menstrual bleeding. Important advice. IUCD has a fertility failure rate less than 1%. IUCD help to control bleeding. So, what do you think, doctors? What do you think? Type your answers in the chat. What about other doctors? So, what about this one? IUCD has a fertility failure rate of less than 1%. Is it correct or not? What do you think about that? Uh, this state. What do you think, doctors? Sorry. What do you think about this state? Okay, let's check here. Contraceptive method and effectiveness. Okay, so this is this chart from John Maratag. Okay, I got this chart from John Maratag. Here, so what about intrauterine contraceptive device? So IUCD. So copper effectiveness. effectiveness is 99.5. So levonorgestrel, this is contraceptive effectiveness, okay? Levonorgestrel is 99.7 and between 99.7 and 99.9, right? So it's a less than 1%, right? That statement also correct, right? Yes, okay, good. Then we do this question. Okay, we do this question and we will go back to our question. 25-year-old woman present to the GP practice clinic requesting contraception. She's sexually active with her long-term male partner and use condoms intermittently. She has no plans to become pregnant in the future and wants to form of contraceptive that helps with her heavy menstrual bleeding. She has regular menstrual cycles with normal to heavy flow for the first 3 days. She wishes to avoid visiting GP clinic regularly for the renewal of the contraception method. She has a medical history of epilepsy and currently takes carbamazepine 400 milligram twice a daily. She has not having other history of breast cancer and smoke 2 to 3 cigarettes per day for the past 4 years and drinks 2 standard drinks per day. On examination, she appears well. Her pulse rate 72, blood pressure 118 by 76, respiratory rate 14, temperature 36.8. Her physical examination is unremarkable and her uterine pregnancy test is negative. Which one of the following is most appropriate contraceptive method? What do you think, doctors? Mm-hmm. Okay, let's check. Here, this 25-year-old woman seeking long-term contraception that will also help manage her heavy menstrual bleeding, right? Like in our scenario, patient is having menorrhagia and she needs contraception as well. It is important to note that she takes carbamazepine, which induces cytochrome P 450 enzyme in the liver and increase the metabolism and clearance of estrogen progesterone hormone. This reduces the efficacy of oral hormone contraceptive as well as progesterone implant. Effective contraception is especially important for this patient as carbamazepine is teratogenic and associated with the increased risk of neural tube defect. Here, the most appropriate option for her is levonorgestrel releasing intrauterine system such as Mirena. It provides effective contraception for up to 8 years and fertility returns rapidly after remove of IUS. The Mirena would be preferred over about Kylena due to the greater reduction of menorrhagia up to 90%. Its efficacy is not affected by enzyme inducing anti-epileptic medications like carbamazepine that she is taking. Yeah. So the question is not exact our question, but in that question also the we have to address for the menorrhagia and contraception both, right? So they have mentioned, so what is best here as Mirena. So here let's little bit discuss about intrauterine contraceptive devices, right? We have levonorgestrel release in IUDs and copper IUDs. Here, what we can see in copper IUDs, it inhibit the sperm migration to upper genital tract, interfering with ovum survival, preventing implantation. So, what we can see in levonorgestrel release in IUD? Thickening cervical mucus to prevent sperm penetration and inhibiting sperm migration to the upper not GI, genital tract, interfering with ovum survival and causing endometrial changes, including atrophy, and prevent ovulation in some use. Like ovulation is most likely to be suppressed in early cycle than with longer duration of use. Here, so anyway, we have to comparison these two as well because as we discussed in previous question, sometimes we should know what is best Mirena or Kylina. Okay, so Mirena here we are using every 8 years, and Kylina every 5 years. So comparative effective on bleeding pattern, more likely to cause amenorrhea or infrequent bleeding than these 9 point mean Kylina. Okay, more likely to cause irregular bleeding than Mirena. Then non-contraceptive indications here. Mirena, we use heavy menstrual bleeding. That's what in that question also they have clearly mentioned, right? So prevent endometrial hyperplasia in individuals using estrogen for menopausal hormonal therapy. And there is no indications other than contraceptive. So best for the heavy menstrual bleeding and contraception both is levonorgestrel IUD, the Mirena 152 milligram LNG IUD. Okay, so remember 52 milligram. Right. Okay, then effectiveness for endometriosis here, endometriosis effectiveness also can be seen, so we can use for that as well. Yeah, that's the main things you should know about this levonorgestrel IUD. So we compared and we got one more question. 28-year-old woman present to the gynecological clinic requesting contraception. She has a regular menstrual cycles and it is currently using condoms. She has no significant medical history and take no regular medications. And she has no significant medical history and take no regular medication. She has never been pregnant. On examination, appear well with vital signs within normal limits, and pelvic examination is normal and CST obtained. She interested in insertion of either levonorgestrel and levonorgestrel or copper intrauterine device for long-term contraception. So they are asking which one of the following describe advice that should be given regarding the copper and levonorgestrel device. So type your answers in the chat. What do you think, doctors? Sometimes they can give these contraception questions as a statement question. So you should know what is the correct one. Mm-hmm. Okay. Mm-hmm. Here, understanding the timing or contraceptive effectiveness for different intrauterine device is crucial for providing appropriate advice to patients. The copper and hormonal intrauterine device work through different mechanisms and therefore have different onset time for contraceptive. The copper intrauterine device provides immediate contraceptive protection regardless of when in the menstrual cycle it is inserted. This is because copper ions create a sterile inflammatory reaction that is toxic for to both sperm and eggs. And this effect begin immediately upon insertion, right? It's a good emergency contraception, right? Here, levonorgestrel intrauterine device provide immediate contraception protection only if inserted within the first 7 days of menstrual cycle. Okay, if inserted at any other time, additional contraceptive protection is required for 7 days. Then, the copper intrauterine device provided immediate contraceptive protection upon insertion. The copper intrauterine device's effectiveness for up to 10 years and can be used as emergency contraception if inserted within 5 days of unprotected intercourse. The levonorgestrel intrauterine device requires 7 days of additional contraceptive protection if inserted uh, after day 7 of menstrual cycle. So please remember these are the good points that they can ask. That's what I have added, even though those are not the question here. So what we should do, what we should give the most important advice here. What is it, doctors? What do you think? In OB, and here our patient is having both things, right? Irregular menstrual bleeding and she needs contraception as well. So what do you think? Mm. Okay, first one is better. First one is better, but in this case, we have to address this irregular bleeding as well. So in that case, what do you think? In that case, A or B? Because patient is having two, we need to address for two cases. First one anyway correct, and the second one also correct because you saw that levonorgestrel, the Mirena is a better option for the menorrhagia as well, right? I think. What do you think? Like opinions, not the answer. Opinion. It says IUD. So do. No, copper IUD not used for menorrhagia, doctor. It's for contraception. Yeah, that's true. In here, they are mentioned about intrauterine contraceptive device, not specifically mentioned about one thing, but the first option is like 100% correct, but it does not address the it does not address the this irregular menstrual bleeding part. But the only option we can go in here is this one. But like I think we in the exam the recaller had more options. Like I think like this option would be better, right? Levonorgestrel release in intrauterine system, or like we can use intrauterine Mirena, I mean levonorgestrel intrauterine device. Like if there's something, some answer like that, so go with that because if we are giving Mirena 52 milligram levonorgestrel intrauterine device, that's the best option for this patient to address his contraception and the contraception and what? The bleeding, right? So I'll add here a note. Look for levonorgestrel IUD, right? Because it's addressed both. But if it is not in the answer, we can go with this IUCD has fertility failure less than 1% because you can see 99.5, 99.7, 90, between 99.9. So it's a very 100% true, and here IUCD help control the bleeding, but they haven't specifically mentioned which IUCD. So in that case, because the copper one is not using, so in that case, we can't go with this answer. We can choose this answer from these two, but if they have mentioned something related to levonorgestrel, so go with that. Okay, that's how the only thing we can tell. Yeah, doctor. So I'll add here note. Okay. So we have discussed. So tell me, uh, If a patient presenting with menorrhagia and asking for the contraception, so what we should recommend? What is the best treatment for that patient? Yeah. Sorry, doctors. My dogs are so annoying sometimes. Yeah. So, yeah, you are correct. So, please remember these points. Okay. Yeah. Mirena is the best of best from IUD devices. So, we have discussed that thing. Can you see for these three questions? It was like 58 minutes, right? My God. Really? Oh my God. I don't think. Yeah. Because they were always like in my near my window. They really like want me to come out. Sometimes they fake their barking and they want me to go outside. Okay, because like I'm the one who is like playing with them, and they always want to play with me. Okay, that's why sometimes they are faking their barking, and they are like children actually. Okay, then it's fine. Okay, but really? Then that's good. Thank you so much for considering it because uh, I'm usually doing my class in near the window and they always there and they always barking. I think my laptop has some noise cancellation. I think that's what. You can't hear them. Thank you, actually. Otherwise, I was always mute because I don't want you to disturb. Because anyway, you are in like a brain fog and you are trying to concentrate. Then suddenly they are barking. Then I feel like so bad. Yeah. Okay. So the next question. Here, a patient present with ear pain and blood-stained saliva with submandibular lymph nodes enlargement. Ear examination is normal. What should be examined next? A submandibular salivary gland, a tongue, nasopharynx, teeth, and gum. So, what do you think? What do you think, doctors? We got A's, C's, and B's. Okay. What else? And D's. Mm-hmm. Okay. This question was very weird in September. Okay. So let's hear. 1 minute, doctor. There's a call. At the same time, please read this one. Okay. Okay. Here. This is RSCGP guideline. Okay, patient present with otalgia. So focused history, complete otology history, including otorrhea, hearing loss, vertigo, aura fullness, tinnitus, and exclude red flags. So and otoscopic examination. In our patient also presented with ear pain and blood-stained saliva and submandibular lymph nodes enlargement. And ear examination normal. So everything is ear in normal. Okay, then let's check what are the red flags. So red flags are associated with oropharyngeal symptom, dysphonia, odonophagia, hemoptysis, weight loss, smoking history, which may suggest a head and neck cancer. So in our case, uh, we got uh, we got only blood-stained saliva and submandibular lymph nodes swelling. Okay, let's check the second point. Progressive or sudden onset hearing loss, no. Eye symptoms, no. Immunocompression or diabetes mellitus, which may allow infection or rapidly progress. So, not right. So there's no red flags. Then treat suspected cause. So if there's an infection, we have to treat it. But in our case, there was no in. They haven't mentioned anything about like other infection features, right? And no apparent causes for otalgia. Like in our case, right? Ear examination, no, everything is normal. Only problem is ear pain and blood stained saliva and submandibular enlargement. Then detailed head and neck examination. And here also red flag, so significant examination finding, we have to refer this patient. And here also no significant finding. Here persistent unexplained notalgia with normal examination. And so here's there is an infection, reassures, symptoms resolve. So then reassess, no clinical improvement, deterioration, then we can treat the complications as well. But this is the part if there is a patient with ear pain, right? Otalgia present. But in our case, there's nothing, right? Or every examination and everything is clear. Then what do you think? Okay, what do you think about this blood-stained saliva and submandibular lymph nodes? Do you feel like any like features related with some cancer? Here, submandibular lymph node swelling and blood-stained saliva. Okay, blood-stained saliva and ear examination normal. And what else? And ear pain, right? So it can be cancer, right? It can be cancer. Okay, so then we have to decide where is the cancer, right? Where is the cancer? So in that case, what we should go? Here, if there is a salivary, okay, if there is a salivary gland problem, so what salivary gland cancer present, how it present? Submandibular salivary gland cancer, how it present? Tell me, like, what is your opinion? Selling or lump, right? So, in here, do we have anything like that? We have only lymph nodes enlargement, right? We have submandibular lymph enlargement. But if there is a cancer, we can see the lymph node enlargement as well. So, what else we can see? What else? And there should be a pain, right? Pain, right? In jaw pain, right? Oh, in here also there can be a referred or referred ear pain, right? Because if there is a cancer in the mouth, in the oral cavity, there can be a referred otalgia, right? Referred pain. That means pain can be radiated into ear, right? So here, yeah. And if there is a parotid, sorry, submandibular salivary gland tumor, so then what else? It also we can see the blood-stained saliva, ulcers, like ulcers or some other lump mass we can feel in where submandibular triangle, right? Irregular mass. So feel in submandibular triangle. So where's submandibular? Let's see. Here, like that. This is a submandibular triangle. So we can see the lump and everything. Okay. Then next, we are going one by one. Okay, it makes sense. Mhm. Ear pain also can be from mandibular this thing, but there's no like hard lump or anything, right? Right? Like in our picture. Okay. Then what about tongue? What about tongue? What do you think about tongue? What do you think, doctors, about tongue? What do you think? What do you think about tongue? Give me one. Okay, so what do you think about tongue? Like, just tell me your opinion. What do you think about tongue? Hmm? Usually, tongue is situated in where? In the base of the oral cavity, right? Judge. Yeah, doctor, the answer is actually tongue, okay? I'm just trying to make a sense because even in September, uh, everyone must mark this as tongue, okay? We got the answer as tongue. So I'm trying to make a sense for you, okay? The answer is tongue, okay? So I'm using the exclusion criteria, then it will make a sense, right? Yeah, because in every question, I'm not just read the question, then answer is that, like that. I'm not like that. Okay, I'm just taking time and uh, like try to think according to like then you will understand it. And in the exam also, you can exclude these other options and think like that. So why is tongue? Is they're asking what should be examined next, right? Not they're asking like where is the cancer or anything. They're asking what we should examine next, right? So, what is the anatomical? place in the tongue. Uh, Usually it's the base of the mouth, right? So there is a referred ear pain, right? Referred ear pain. So in this case, like the answer is tongue, okay? But I need to make like okay, we will keep tongue for later. What about nasopharynx? So what about nasopharynx? What about nasopharynx? So tell me your opinion. Why not nasopharynx? If there is something related with we need to like more focus details in nasopharynx. So usually if there is something we can see epistaxis, right? And some blood stain mucosa from the nose, right? But in this case they haven't, like, this is not very related to the nasopharynx, right? Then what about teeth and gums? What about teeth and gums? Tell me. What about teeth and gums? Tell me. When we should consider about checking on teeth and gums. If there is a bleeding from gums, teeth, right? Like as example, if there is some problem with gums, like some like blood clotting disorder, when patient is brushing the teeth, there can be a bleeding, right? Minor bleeding. As example, like von Willebrand disease, there can be a mucosal bleeding, right? Gum bleeding. So in our case, it's not related to those pathologies, right? So yeah, gingivitis, bleeding, gum will stain saliva, but it does not describe ear pain, right? Okay, even though if patient is having gingivitis and blood stain saliva, it doesn't make any sense with ear pain, right? Referred ear pain here, ear pain and lymph node enlargement. So this does not, and nasopharynx does not make any sense. So here, what about A and B? Let's talk about the tongue. Tell me, doctor's tongue. What do you think about the tongue? What do you think? Mm-hmm. Yes. Why most likely? I want the explanation from you. I want the explanation. Yeah, toothache also can be referred to here. But what about the submandibular lymph enlargement? Let's like one by one. Okay, ear pain. Ear pain, even like when we consider with other submandibular lymph node enlargement and blood stain saliva. We can think like, and the ear examination is normal, right? There's no any pathology in ear. So this is the referred ear pain. Okay. And this ear pain can be from somewhere else, right? Okay. It can be radiating from somewhere else. So it can be from mouth, oral cavity, right? Then so it can be like tongue, throat, right? Then why? Because it has the like as the doctor mentioned in due to the nerve involvement, right? Yeah, yeah, doctor. Yeah, yeah. Something related with the salivary gland cancer. But the question says, yeah, they are asking what examination we should do. So in that case, we have to do the oral examination, right? The throat examination. So best in from these three, it can be tongue, right? Because they have already have a look about this submandibular, like they have noticed about this submandibular lymph nodes enlargement. So and it can be something related with cancer, something related with submandibular gland, but they are asking what we should examine next. Outlet examination. Yeah, doctor. According to that chart, that's what I have added this one. Okay, so we have to do the full examination of head. Okay, here detailed head and neck examination. So if the fifth answer is that, I think better to go with that, right? But here we need to like they ask it specifically. We only got here these things. So, what do you think? Is A or B? Mm-hmm. Okay, yeah. Yeah, that also a good point, right? SCC of tongue cause referred pain or talgia, yeah, and blood stains saliva. Yeah. So, what do you think? Are we going with tongue because they have? So, can we be as overall? Yeah, yeah, yeah. Overall, like the tongue make more sense, right? Here. And the thing is here, like they haven't mentioned anything about the submandibular gland, not the lymph nodes, like submandibular salivary gland, swelling or hard lump or anything. So in that case, first we should better to go with tongue, better to go with tongue because we don't see any irregular mass or anything in that submandibular triangle, right? As I showed you. And yeah, better to make a investigations of tongue because it's in the base of the cavity, base of the oral cavity, right? So better to go with that. Better to first check in the oral cavity, right? So I think so. Tongue is makes most. So I have, and this is from RSEGP. Tongue cancer is one of the most common site of head and neck malignancy. Smoking, drinking, alcohol, and more recently, HPV infection are recognized as the major risk factors for the development of tongue cancer. Most of the time, surgery is a recommended therapy with radiation and chemotherapy also. have an important role. This activity outlined the evaluation and management of tongue cancer, highlighting the role of the professional team of improving care for the condition. So here I have added for the tongue cancer as well. So here the tongue cancer is the most common sites of head and neck malignancy. Not because of that we are going with the tongue, because of these the features that we mentioned, like the tongue shares the nerve supply with ears, so disease can cause the ear pain when ear looks normal. Therefore, tongue should be examined next. Okay, so simply I have added, but I was waited this time because I want to get the answers from you, like why this is not like that. Okay, yeah. And you can go through this one as well. This is a good chart for otalgia, how we should investigate this. Okay. Here, so tongue make more sense, right? Hope you agreed. So the next question. A woman presented to the GP on Monday after having sexual intercourse with unknown partner on Friday. She has 26 to 30 days of menstrual cycle and her last menstrual period was 2 weeks ago. Okay. Then, where was I? Yeah. She is not taking oral contraceptive pills regularly and usually use condoms with her boyfriend. Next step. What do you think? This patient is using condoms with her boyfriend, but had a unprotected intercourse with the unknown person, right? What kind of person is this? What do you think, doctor? She like to get HIV, right? I think. I'm just kidding, okay? She, yeah, doctor. Because when I was doing this question in the September volunteer classes, also some doctor has pointed out that, so I never forget that one. Why she is using condom with his boyfriend and why not using with the unknown person, right? Yeah. Okay, so tell me your answers. What do you think? Mm-hmm. Okay, from these A, B, C, D, what do you think? Is it HIV prophylaxis or is it emergency contraception with levonorgestrel? What do you think, doctors? Just type your answers. What do you think? We got C's, we got B's. Yes, that's the point I want you to ask. Okay, yeah. So very good, Dr. Bhagya, because I have explained this point, okay, in HIV theory session. The thing is here, before giving HIV uh, post exposure prophylaxis, we should consider some points, right? Okay. Okay, let's go one by one. Assessments of adults after possible exposure to bloodborne viruses. So here, so HIV is a bloodborne virus. So what we should do, this is a common for all bloodborne viruses. So clarify if an exposure or a near miss situation occurs. Then near miss occurs occurred rather than a definitive exposure. So if it is a near miss one, reassure the person, ensure the person is assessed for the appropriate prevention measures in case of future exposure. That's pre-exposure prophylaxis. It's not the topic today. And provide advice about avoidance potential future exposure. Okay, then obtain details of the exposure, including time, nature of the exposure, and details of the exposed person and the source. Perform a risk assessment of the exposure, taking into account type of exposure, type and amount of fluid involved, infectious status, and susceptibility of the exposed person. Then test the source, if possible, for hepatitis B, hepatitis C, HIV, and if the source is hepatitis C antibody positive, perform hepatitis C polymerase chain reaction. Okay, we have discussed why. Then test the exposed person for baseline hepatitis B surface antibody and store the blood sample in case further testing. In case of sexual exposure, test the exposed person for other sexual transmitting pathogens. And for people who have menstrual cycle presenting within 5 days of sexual intercourse, offer emergency contraception. Mhm. Then, so here, general principles for the management of suspected or confirmed exposure to HIV in adults and children 16 years and old. This can be suspected or confirmed exposure. Here, testing requirement. If the source is HIV antibody antigen negative and unlikely to be in the window period, no further follow-up testing, no source or exposed person required. If the source is HIV antibody antigen positive or HIV antibody antigen negative and likely to be in the window period, the exposed person should have HIV antibody antigen testing at the baseline 4 to 6 weeks and 3 months after exposure. In this, people who do not receive HIV post-exposure prophylaxis, the likelihood of seroconversion in 6 weeks after exposure using current standard assay, the fourth generation test. Okay, it's a screening test. HIV antibody antigen test is very low. And people that receive HIV post-exposure prophylaxis should have HIV antibody antigen testing 3 months after exposure. So these are the tests. So post-exposure prophylaxis. Here, recommended for post-exposure prophylaxis against HIV depend on the exposed person's risk acquiring HIV infection. If indicated, start post-exposure prophylaxis as soon as possible within 72 hours of exposure. If it has been longer than 72 hours since exposure, we have to refer this patient. Okay. Then, okay, do not. Okay, this is the thing. So I have added only anal intercourse and vaginal intercourse. Yeah, only. Okay, here. So, anal, because these two are the very high risk of getting HIV. So, source of HIV, in our case, HIV status of source is unknown if it is a anal intercourse. In that case, what we should do, very high prevalence population like men who have sex with men or who also inject drugs. In this case, we can use three drug regime and a high prevalence population men who have sex with men or from high prevalence country. In that case, post-exposure prophylaxis is not recommended unless the sexual exposure was receptive anal sex or insertive anal sex and the person is uncircumcised. Okay, if so, use free two drug regime. Okay, then what about vaginal intercourse? Source of unknown, very high risk who are MSM with drug inject with MSMB who also inject drugs. So in that case, use free drug regime if the patient is not high prevalence. PEP not recommended. So not in every cases we are not giving PEP. So we have discussed this part in our theory session as well. Sorry, I could not upload it in the YouTube, but tonight I will upload everything. And what about emergency contraception? So, what are the emergency contraception method we have? So, I have noticed most of doctors have confused this emergency contraception with other contraception. Okay, so what are the main emergency contraception we have? So, tell me those. What are those? Tell me different types of emergency contraception. Okay. Okay. What else? Mm-hmm. Remember, we have progesterone only pills, right? We have levonorgestrel pills, ulipristal acetate, okay, ulipristal acetate pill, and copper IUD. So these are the main three emergency contraception that we use. So what are those again? 1 minute. What are those? Tell me. We have levonorgestrel pill. We have ulipristal acetate pill. We have copper IUD. Right. So you should know what is the time duration that we can apply these emergency contraceptions. So what about ulipristal acetate? So what about ulipristal acetate? Tell me. It also progesterone receptor modulator, right? But it has a good advantage. What? Then levonorgestrel. Tell me. You should know these are very high. So if you have any doubts, okay, I had so much doubts while I was preparing for contraception part. Okay, then I got the e-medicine. I did all the questions for contraception. Okay, then I got a clear idea about contraception. Okay, so please listen carefully. Okay, we you should remember about these. Uh, okay, I'll just listen. Okay. For ulipristal acetate, it also progesterone modulate. In here, we are giving 30 milligram oral dose, right? It's a single dose and we can give it within 5 days. What about levonorgestrel? Levonorgestrel, we use 1.5 milligram as a single dose. Okay. Or if the patient is more than 70 kilogram or BMI 26, double dose, it should be within 4 days. Okay, within 4 days. Or and 25 levonorgestrel POP, 25 to 30 MCP as an initial dose, then repeat in same dose as 12 hours. This is a two dose, one levonorgestrel 25. Then what about copper IUD? It also we can insert within 5 days. But levonorgestrel, remember, it's usually within 72 hours. Better if you can give it's within 72 hours. Here, let's read this. A ulipristal acetate is a selective progesterone receptor modulator that acts by preventing or delaying ovulation. It does this more effective than the levonorgestrel emergency contraceptive pills, which license for only up to 72 hours after intercourse. Effectiveness for both is improved earlier they are taken, right? The copper IUD is highly effective 99% and can provide very reliable ongoing contraception. It may be appropriate to advise women seeking postcoital contraception to return for pregnancy resulting in 3 to 4 weeks, and depending on high risk STI screening and need for ongoing contraception is considered. We will go to our question after doing this question. Okay, a woman presenting requested emergency contraception after unprotected sexual intercourse 48 hours ago. Her doctor prescribed her levonorgestrel emergency contraception. Which one of the following is best describe the primary mechanism of action? What do you think, doctors? You should know. Good. Here, I have had this question because this question is having a good things. You can get levonorgestrel emergency contraception primarily work by preventing or delaying ovulation. It does this by suppressing surge to luteinizing hormone that triggers ovulation. It does not delay fertilized ovum. However, if ovulation has already occurred and fertilization happens, it may also prevent implantation of fertilized ovum. Then, here levonorgestrel is most effective when taken within 72 hours. Please remember. So, uh, for levonorgestrel, remember it's better within 72 hours of unprotected intercourse, though it can be given up to 120 hours, but better within 72 hours. The copper intrauterine device is most effective form of emergency contraception when inserted within 5 days of unprotected intercourse. The third emergency contraception is ulipristal acetate, which works by delaying ovulation by inhibiting progesterone receptors and is effective up to 5 days. So, so remember for copper IUD and for ulipristal, it's usually 5 days, but levonorgestrel, the best we can take within 72 hours, within 3 days. Okay, right? Yeah. So, yeah, have added that question because they have mentioned about here. Yeah, and here I have added another table, and you should know about uripristal acetate. That they have a comparison table. Sorry. I mean, what you ask in levonorgestrel? The mainly they are using this one, wait. Levonorgestrel, the single dose one, okay? Because POP we using 25 levonorgestrel we use as the 12 dose. But here the best thing is here levonorgestrel, the single dose one, okay? Yeah. Usually we are giving this part in Australia. Let's discuss about here also. This is a comparison table. Um, Here, most effective oral method is ulipristal. Why? Because it has a long period, right? Like 5 days, the effectiveness period. And here, not as effective as ulipristal or copper ID may have reduced efficacy with the increased PMI. Here, what else? Here, with 72 hours. Yeah, the same thing, doctors. You can just give it a rate. Other things also I have added the side effects and what we can do the breastfeeding. This is from a RICGP guideline. Okay, there's a contraception guideline, but you don't have to read everything because everything is here for emergency contraception. Okay, yeah. And emergency contraceptive method recommended. So, decision about what we choose. The timing of presentation from unprotected sexual intercourse. If the presentation is at 72 hours following unprotected sexual intercourse and oral emergency contraception requested, UPA has the greatest proven efficacy than levonorgestrel. Okay, then if there is a chance that ovulation has occurred, then the copper IUD is the only method that will be effective. Then, the risk of further unprotected sexual intercourse and the pregnancy risk of the delay in commencing ongoing contraception. Hormonal contraception cannot be commenced within 5 days of ulipristal, but it can be started immediately with levonorgestrel emergency contraception from BMI. So we have to change the dose and use enzyme-induced drugs like carbamazepine. So it's depend on usually estrogen one. They have mentioned here that as well. Mhm. So yeah, and copper is the like best one, right? Most effective methods. Why? What is happening in here? What copper IUD do actually? What is the mechanism of action of copper IUD? Tell me. Tell me. What can the copper IUD do? We discussed. Yeah, we just discussed, doctor. Do you remember? In the beginning, we have compared the IUDs.
Yeah, it actually makes the endometrium unsuitable for the implantation.
Mm-hmm. Yeah, good. It's a inflammatory. They have make a inflammation, right, in endometrium. Yeah, they then can prevent implantation, and it's not good for both sperms and ovule, right? Yeah. So yeah, most of the contraception we have covered today, right? So what do you think in this case? And here, patient is present in after like how many hours patient is had the sexual intercourse in Friday, right? Friday, so Saturday. I think it's as a thing like a Friday night, Saturday night. It's within 72 hours, right? Right? Or not? Tell me, so what do you think? Can we give levonorgestrel? Why you all are silent? It's within 72 hours, right? Yeah. And what about she has a her last menstrual period was 2 weeks ago. So 2 weeks ago means she's in. ovulation, right? Like around ovulation period, right? And there's a pregnancy risk as well. So we have to think about prevention of this pregnancy. So better we can go with levonorgestrel emergency pills. Mm-hmm. Yes. Okay, good. Mm. There was a scenario that we just discussed yesterday, right, doctors? This question. Okay, tell me the answer. Tell me the answer. Tell me the answer, doctor. Hurry up. We don't have much time. This question, do you remember? Mm-hmm. So, like, what we should look in this in the options? Like, what is the other answer? Like a best answer. If it is in the option, so what is that? Yesterday I have explained. Yeah, assessor capacity. Okay, good. Mm-hmm. Okay, a scenario of a boy with constant sneezing and cold all year around and worse in the winter. Some other pointers to A to be present. Asking for what to confirm diagnose, measure IgE, skin prick test to allergen. So what do you think? What do you think, doctors? Tell me your answers. What about other doctors? Why skin prick test? Why not IgE? Tell me the reason. In every cases, you should know why you should exclude other answer. You should have a reason. Hmm. Okay, what is the diagnosis of this case? What is his diagnosis? This one. What do you think about this case? It's look like allergic rhinitis, right? Okay. Let's do this question, then we will go back. A 25-year-old woman present to the GP clinic with 2 months history of itchy rash. She has history of mild atopic dermatitis since childhood, which has been well controlled with using daily topical moisturizers. And she has not need steroid cream since primary school. She takes no regular medications, and her symptoms began shortly after moving into a new share house with six other housemates. She reports increased itching and redness on her arm and neck, and she also notes sneezing and itchy eyes. On direct questioning, the mentions her new housemate has the three cats, but the cats have regular care for fleas and ticks. The patient thinks she might have noticed similar symptoms when she stayed with her auntie on the farm as well. On examination, she appears well with vital signs within normal limits, and there are erythematous scaly patches with excoriation marks on her neck and antecubital fossa. She has a bilateral conjunctival injection and clear rhinorrhea. So there are skin. What is the most appropriate next step in diagnosis? Patch testing, skin prick testing, total serum IgE, trial of oral antihistamine, food allergy panel. So what do you think? What do you think, doctors? Type your answers in the chat. What do you think, doctors? Okay, let's check. Okay, let's check why. Here, this patient present with worsening of atopic dermatitis and new onset allergic symptoms temporarily related to cat's exposure. The combination of a skin manifestation with respiratory and ocular symptoms strongly suggests pet danger allergy as trigger. So allergies to cats are the most common mammalians origin allergy in human. Skin prick, skin prick testing is a gold standard for diagnosing specific allergies, including pet dander. In the presence of rhinitis, asthma, atopic dermatitis, potentially food reactions, it is reasonable to perform skin prick testing to determine specific IgE allergies despite the presence of active eczema. A skin prick test can be still performed on unevolved skin. It provides rapid result within minimal side effect and can help confirm the specific allergen triggering both cutaneous and respiratory symptoms. So why not IgE level? May be elevated in patient with atopic conditions, but it is not specific. It is non-specific and does not identify the particularly allergen causing symptoms. Okay. So this is non-specific. So that's why we are not doing IgE. Okay, so let's little bit discuss about allergic rhinitis. Okay. Do you remember that chart in therapeutic guideline for the allergic rhinitis or not? Tell me, do you remember or not? Do you remember the management chart in therapeutic guideline? Yeah, right. Good. Okay, so you have to follow that. So, what are the types of rhinitis? We have allergic rhinitis, allergic and non-allergic, then non-allergic rhinitis. Okay, allergic, seasonal allergic rhinitis, hay fever, or um, perennial allergic rhinitis. So, these are the classification here for overall rhinitis. So let's discuss about allergic rhinitis. Allergic rhinitis is classified in terms of symptoms and frequency and duration. So what are those? We have intermittent allergic rhinitis. We have persistent allergic rhinitis according to the frequency and duration. And we have mild and moderate to severe allergic rhinitis according to severity. So, what is the intermittent allergic rhinitis? Symptoms persistent on a fever than 4 days per week or fever than 4 consecutive weeks. Persistent one symptoms persist on more than 4 days a week and more than 4 consecutive weeks. So mild mean symptoms persist but not troublesome, no sleep disturbances, no impaired daily activities, leisure or sport, no impairment of school or work performance. Moderate severity, One or more following here: troublesome symptoms, sleep disturbances, impaired daily activities, leisure sport, impairment of school and work performance. Here one or more, and here all of following, okay, present in mild cases. Then you should follow this chart for treatment of allergic rhinitis, okay? First, you have to categorize a patient needs having mild symptoms or moderate to severe, so you know how we should take it as mild or moderate to severe. So mild symptoms, we have to start from the oral or intranasal antihistamine. Oral or intranasal antihistamine, we have to start. Then we have to check symptoms is resolved or not. If symptom is not resolved, we have to treat it as moderate to severe symptoms. Okay. So if the symptoms is resolved, then we can continue treatment with the minimal effective regime. Okay. So if treatment is working, we have to continue the treatment. Then moderate to severe symptoms or symptoms not resolved in mild cases with oral or intranasal antihistamine. In that case, what we should use? Oral or intranasal antihistamine plus intranasal corticosteroid. So we are using here two drug regime, right? Oral or intranasal antihistamine with intranasal corticosteroid. So then we have to check if it is working or not. If it is working, we have to continue the treatment. If it is not relieving, the symptom is not improving, then what we should do? Here, then we have to consider if it is persistent or intermittent. If it is persistent nasal obstruction present, use intranasal rather than an oral antihistamine. Trial of combination or intranasal histamine and corticosteroid formulation. So here, a better use with intranasal antihistamine plus corticosteroid, right? Then persistent ocular symptoms, add an eye drop with antihistamine or mast cell stabilization properties. For intermittent allergic rhinitis, so you know how to categorize here according to this. For the intermittent allergic rhinitis, consider adding Montelukast. So please remember these things, okay? Then symptoms relief, we have to continue with. Not relief, we have to refer this patient. Okay, so that is simply for the allergic rhinitis. It's very simply. Okay, so you should remember about that. Then, a minute. Yeah, that's all, doctors. Mhm. So, we have just discussed everything about allergic rhinitis. So, answer is skin prick test. Okay, so doctors, we will take 5 minutes break, not more, 5 minutes. Now the time is 8. I'll come back after 8 part. No, 8:06. Okay, have some tea, coffee. Oh, it's something I know your brain is not braining properly right now, but you have to put together your brain, right? Because you need to think in March you are having exam and some doctors February as well. So be calm and listen and concentrate, okay?
Recording.
Oh, sorry, I haven't start the recording. Oh my God. Sorry, doctor. So I have to read this. Okay, we just start from this question, right? Okay, I'll read this again because some doctors are not able to join the live sessions and Sorry for that. Oh, why? I just noticed it. It's fine. So the here 4 months old baby came with mother. Mother is very concerned about the baby because it's only presents once in 6 days. Very irritable 24 hours before passing the motion and will pass out massive liquid stool. Previously, one day, 4 times, bowel opening and drinks hungrily and regurgitate milk. So management, here our baby is 4 months old. I'm sorry for that, okay? Sorry for I forget to start the recording. That's why I'm reading again. And here, what you can see in this question. So before that, we will read this part, okay? Constipation affect the one-third of children and frequently occurs during the introduction of solid food and toilet training and school. Most children defecate at least every 2 to 3 days. This is the normal defecation frequency in most children, but we have an exception in where if the patient is breastfed babies, they have the infrequent level like once in 7 days. Okay, that is for breastfed babies. But in our case, they haven't mentioned anything about breastfed baby. So this can be a non-breastfeeding baby, like formulated fed baby. Okay, so that's mean and this is abnormal because the usual bowel opening should be in 2 to 3 days, but in here, after 6 days. So there is some problem, right? There's a constipation here. And so, what are the wrong four criteria? So, wrong four criteria is must include equal or more than two criteria for at least 1 month in infant or 2 months in older children. So, this is wrong four criteria for diagnosis of functional constipation. So, what are those? Less than or equal to stools per week and history of retentive posturing or excessive sorry, volitational stool retention like withholding and incomplete evacuation. Then history of painful or hard bowel movement, history of large diameter stool and presence of the large fecal mass in the rectum. And in toilet trained children, the following additional criteria be present: at least one episode per week of soiling or incontinence after the accession of the toileting. Okay. So, what are the red flags? So, these are the red flags you can read because in our case there's no red flag. So say less than 6 week, delayed past meconium, ribbon-like stool, weight loss, poor weight gain, persistent vomiting, abdominal mass. So here also they are explaining the same thing. Okay, then how we should examine? We have to examine the abdomen because in some cases, like feces are collected inside. So in that case, we can palpate it, right? We can feel hard mass on it. So palpable feces and lower back spine, neurological examination, perianal area, because we have to make sure if there is any fissure or anything like that. An internal examination should be not performed without first consulting the senior clinician. An impaction, hard mass in the lower abdomen and soiling from overflow. In our cases also, our patient is having the massive liquid mass, right? Due to this, it can be due to infection or an overflow, right? Yeah, impaction. And investigations, there's no routine investigation. So how we treat? So before the treatment, we have to make sure if there is any impaction or not. If there is any impaction there, so if there's any impaction collected stool, we have to remove them first, right? Otherwise, there's no there's no effectiveness of the treatment for the constipation, right? First of all, we have disinfect. So after that, we have to give these treatment modification, behavioral modifications like position, toilet seats, charts or diary, encourage child to be exercise more, okay, like that. Then dietary modification, we can encourage child to give the more dietary foods, and some children are having some connection with the like cow milk intake, and it can reduce the dietary fiber, so that it can also lead to the constipation. So in those cases we have to prevent this cow milk. And so medications according to the age. Infant less than 1 month, coloxil drops. 1 to 12 months, isosmotic laxative like macrogel or electrolyte or lactulose. So children, isosmotic laxative or lubricant. And children with stool withholding behavior, pain while defecation or rectal bleeding fissure may be benefit from inpatient disinfection. So how we should do disinfection? We can use oral disinfection like macrogel, right? Plus electrolyte sachet. And we have inpatient management. Here is outpatient management. Here we have inpatient management. Here so we use macrogel electrolyte solution. So this is the formula we use. So that's for constipation, functional constipation overall. So the question is, 3-year-old girl present to the GP practice clinic with her parent with 3 months history of intermittent abdominal pain. She has been constipated, only passing 1 to 2 stool per week, despite having been toilet trained 6 months ago. She has had 3 episodes of fecal incontinence over past 2 weeks, and she started childcare 4 months ago, and parents are unsure whether she's passing stool at childcare, and she has not vomited, and parents not concerned about weight loss or poor growth. She has no other significant medical history and does not take any regular medications. Then on examination, she appears well, and abdomen is generally tender, and blood pressure also 90 to 60, and generally tender, but the pain is distractible, and there's a palpable mass in the left lower quadrant. So, which one of the following most appropriate next step? So, so you all selected different answers. So let's check. Here, we all know functional constipation wrong for criteria. And here, as this child experiencing persistent abdominal pain, encoparesis, and has fecal loading on examination, oral stool disinfection is required. High doses of macrogel are used for stool disinfection and should be continued for several days until there is a large amount of stool passed. Then the maintenance stool softeners are continued for at least 3 months, right? This can all be done at outpatient. So answer is oral disinfection. Here commence oral stool disinfection because there is a massive collection of the uh, stool, right? So yeah, so that's the answer, doctor. And here, why not macrogel or polyethylene glycol? Here, maintenance treatment will macrogel or polyethylene glycol is appropriate following disinfection and should be continued for at least 3 months. So, what we can see, if there is a if there is a stool impaction there, first we have to remove them, right? Otherwise there is no point, right? So in that case, first disinfection if there is only a hot stool collected in the abdomen, right? If there's no disinfection, we can continue our treatment accordingly. But in this case, there is an impaction of stool, and first we have to disinfect. Then uh, we have to use the maintenance therapy like stool softeners. Okay, so that is how we should manage. We have to do oral disinfection initially, yes, followed by maintenance therapy treatment. Yes, doctor. Yeah. First, we just simply remember if there is a impaction, we have to like disinfect, right? We have to remove them. For that, we can use disinfection, like they have mentioned here, macrogel. Yeah, macrogel and electrolyte solution. We can do the inpatient and outpatient, and then we have to use these treatment, right? The soft these like stool softening agents like lactulose, right? So we can use coloxical drop like that. So let's go back to our question. What we can see in here, a 4 months old baby, okay, we diagnose this as constipation and very irritable 24 hours before fast in motion, and massive liquid stool has passed out. And previously, one day, 4 times pure and drink hungrily and regurgitate milk. So, what do you think, doctors, in this case? Is it lactulose, something suppositories, or probiotic? What do you think?
Lactulose.
Mm-hmm. Because there's no impaction and there's no palpable mass. So, in that case, the best thing we have to from these three answers lactulose, right? Hope you all understand it or not. I have explained twice today the same topic. So, what do you think? Do you understand or not? I don't know if you understand or not. Please ensure that okay you understand. Now you know. So, for you, how to in this topic you should know what is the wrong for criteria, and you should know in breastfeed babies defecation frequency and non-breastfeed babies defecation frequency, because otherwise you can't consider this as constipation or not. Okay, so you should know that, and you should know then we have to do the physical examination and check if there is a palpable mass, right? Palpable mass, because we should make sure first if there is an impaction or not. If there's infection is present, we have to disinfect this impact first. Then we have to continue the maintenance therapy, right? If there's no disinfection, we can just give the treatment according to that age period. Okay, so you should remember all of these things. Yeah, that's all for this question. So in here, the only answer we could got is lactulose. So we can go with. Mhm. Yeah. Next one, a man with painful defecation. He could feel nodules around anus. I think 5 days gone, but will you see on the examination? So, what do you think, doctors? This is thrombosed perianal hematoma or internal piles. What do you think? What do you think, doctors? Mm-hmm. Okay, so what are the types of hematoma? So, not hematoma, sorry, hemorrhoids. So, what are the types of hemorrhoids? We have internal hemorrhoids and external hemorrhoids, right? Okay, let me discuss about it. Mm, okay, I have added the all anorectal pain features, but I have discussed this in the previous sessions. Okay, this table, but still I have added this because this is everything for anorectal pathologies. Let's little bit discuss about hemorrhoids. So, what are the hemorrhoids or piles? Are enlarged, displaced vascular anal cushions containing a rich arteriovenous network, which are subject to downward pressure during the defecation. Hemorrhoids are classified as external or internal based on their position above or below the dentate line. You all know what is dentate line, right? Okay, I'll show. Here, this is the dentate line. Okay, according to this dentate line, we are deciding the position and categorize into the types. So, what are the internal hemorrhoids? Internal hemorrhoids has what we can see in internal hemorrhoids. Internal hemorrhoids originate above the dentate line and have columnar epithelial, and that is insensitive, uh, insensitive to touch or temperature, so they are not typically painful. So the usual internal hemorrhoids are not painful. Okay, so remember, then internal hemorrhoids are diagnosed using medical history, physical examination. Symptoms and internal hemorrhoids include bleeding, mucosal discharge, and pruritus. Then these internal hemorrhoids can be prolapsed right down the anal canal. Hmm. According to these prolapses, we categorize these into grade 1, 2, 3, and 4 internal hemorrhoids, right? Here you can see. So you can read this later. I'll explain from here. So grade 1 mean hemorrhoid does not prolapse. So there's no prolapse. Okay. Above dentate line. The grade 2 hemorrhoids prolapse during the defecation and reduce spontaneously. When the patient is straining, this prolapse come down. This hemorrhoid can prolapse, but spontaneously it's go back. The grade 3 hemorrhoids prolapse and require manual reduction. So, when patient is straining, defecating, these hemorrhoids are prolapsing, but it's not going back spontaneously. We have to manually use our finger to insert it inside. Okay, right there we can. The patient has to use manual reduction. So remember, it's a manual reduction and this is a spontaneous radius. So grade 4, hemorrhoids prolapse and this is not, uh, we can't reduce this one, okay? Grade 1, no prolapse. Grade 2, prolapse with a spontaneous reduction. Grade 3, prolapse with manual reduction. Grade 4, prolapse without reduction. Okay, so remember that. So how we should manage these patients? So, internal hemorrhoids. Here, you can follow this chart for internal hemorrhoids management. Okay. First degree, if there's a no prolapse. So, no prolapse mean we can use the conservative management, high fiber diet usually. Remember high fiber diet and what else they have mentioned here. Yeah, high fiber diet and non-caffeinated fluid should be avoid straining during defecation. Okay, so these are commonly. Then so with prolapse what, if there is a prolapse there, we should treat those. Okay, we should treat those. And um oh, the first one, the no prolapse one is failure to improve. Still, we have to go with the treatment. So, treatment also categorized into degree. Second degree mean what, prolapse present, right? And spontaneously reduced, right? Here, prolapse present, spontaneously reduced. So, how we should treat this? Ligation or injection. We can use ligation or injection. So, third degree, the manual reduction, and fourth degree, no reduction. So, both these two, we have to use the surgery. So, very easy. Grade 3 and 4, the mainstay treatment is surgery. Grade 2, we can use injections and ligation. For grade 1, conservatively, we can manage. Okay, then, so how we should manage these external hemorrhoids? We have thrombosed external hemorrhoid, right? So I'll show. Here, this is the thrombosed external hemorrhoids, or we call it perianal hematoma. Here, you can see perianal hematoma or thrombosed hemorrhoid. So how we should manage these thrombosed hemorrhoids? These symptoms are, what are the external hemorrhoid symptoms? So external hemorrhoids are painful, right? Painful, and they are itchy, right? Discomforting, and they are itching and here, what else? Yeah, here. And external hemorrhoids also. This is a type of external hemorrhoid. Okay, thrombosed one, a type of external hemorrhoids. Okay, so here a thrombosed external hemorrhoids, a perianal hematoma, appears as extremely painful, tense, blue swelling at the anal margin. So like this. Here you can see this one, right? Yeah. So then, although sometimes called perianal hematoma, and here, yeah, the clot is contained within the endothelium lined blood vessels and it is not true hematoma. Okay, this is not a true hematoma, even though we are calling this perianal hematoma. Okay, so please remember. So, how we should manage? Here, usually for patients who present with 72 hours of the onset symptoms, severe pain can relieved by excision. Okay, so remember within 72 hours, we have to do the excision. Within 27 hours of the, 72 hours of onset symptoms, we have to do the excision. Okay, we have to do the excision. So this is the mainstay of treatment. Excision of the hematoma under local anesthesia. To avoid recurrence, it's important to excise the entire hematoma, leaving an open wound. Simple incision should generally be avoided because higher rate of recurrence and may worsen the symptoms. So this is all for hemorrhoids. Okay. They just asked us to uh, identify the diagnosis, but I have explained about the hemorrhoids. And yeah, he could feel nodule. I think this can be thrombosed perianal hematoma, right? Okay, because it's a painful identification. Okay, the next question. A 24-year-old woman present with lower abdominal pain and mild vaginal bleeding. Her last menstrual period was 5 weeks ago. She is hemodynamically stable on examination. Best investigation: pelvic ultrasound, quantitative serum beta HCG. Other options couldn't recall, and no urine pregnancy test in option though. So what do you think? We have done the same kind of question in November, and I showed you what we should do first in these kind of scenarios. So tell me what we should do first and why we should do that. A reason and what we should do. Why pelvic ultrasound? Why? Mm-hmm. Okay. Let's discuss this question. Do you remember? I got this from our November 5. Okay. So, 16-year-old girl present to the emergency department with 12 hours history of nausea and lower abdominal pain associated with urinary frequency. She has regular 28 days menstrual cycle and her last period was just over 4 weeks ago. She does not take any regular medications. On examination, she appears unwell. Her pulse rate is 90, blood pressure 112 by 78, respiratory rate is 18, and SpO2 98 on room air. And temperature is 37.6, and she is tender in the right iliac fossa. Which one of the following is most appropriate next investigation? What do you think? Okay, now tell me the answer. They also ask most appropriate next step. Okay, why here you select urinary beat HCG and why here pelvic ultrasound? So why tell me why you select two answers in there? Why? You should have explanation. Just explain me, hurry up. It's already 9. Tell me, doctors. Mm-hmm. What do you think about quantitative serum beta CG? What do you think about this test? What do you think? Mm-hmm. Okay, then why pelvic ultrasound? Have mm-hmm. Okay, okay. Do you revise November 5 or not? Mm-hmm. Yeah, the serum one is more specific, right? Anyway. Okay, let's go through that question here. Let's check about what they are telling about serum beta CG as well. The case of present 16-year-old girl with symptoms that could be consistent with several conditions, including ectopic pregnancy, UTIs, appendicitis, or ovarian pathology, given her age and sexual maturity. Pregnancy related complications must be considered and ruled out first. So, urinary beta HCG is the most appropriate next investigation. It is rapid, non-invasive, and highly sensitive test that can quickly determine if the present of if the patient is pregnant. This inform I will add the proper picture, doctor. This is not a screenshot, but I yeah something is not clear, right? I will add it. Don't worry. And this information is crucial for guiding further management and investigation. A positive result would be raised suspicious of ectopic pregnancy given in the patient's symptoms and would prompt immediately further evaluation. Then let's check about serum beta HCG. More sensitive than urine test and can provide quantitative result, however take longer to process and not necessary as the initial test. If the urine test positive or if there is a high clinical suspicion despite negative urine test, serum beta CG then would be appropriate. So let's check about the transvaginal ultrasound. Is important investigation in the evaluation of suspected ectopic pregnancy. However, it should not be performed before confirming the pregnancy status with beta CG test. Addition in 16-year-old patient who may not sexually active less invasive and approach should be considered first. And here ectopic pregnancy should be always considered in women in a childbearing age who present with sudden onset low abdominal pain. And urinary beta HCG test is rapid, sensitive, and non-invasive first-line investigation for suspected pregnancy. So now, what do you think? What do you think? Still pelvic ultrasound or like quantitative beta HCG? First, we have to check the patient is pregnant or not, right? Yeah. Yes, blood intake time. Yeah, it take time, but it's still first in that case also they have mentioned before ultrasound we have to make sure the patient is what, pregnant or not, right? So better we have checked the quantitative serum beta hCG, right? Because they are not telling the patient is hemodynamically unstable or like that patient is stable, and the 5 weeks ago last period, and patient with low abdominal pain and mild vaginal bleeding. So next is, I think, better we can go with no option correct. The recorder mentioned there's no urine pregnancy test, so we have to anyway exclude that, right? So in that case, I think better to go with quantitative serum beta hCG, right? Hope you understand this one clearly or not. Is still pelvic ultrasound. What do you think, doctors? What do you think? Yeah, I have heard it. Okay. If urine beta hCG available, it is fast, cheap, sensitive. Okay. And quantitative confirms pregnancy, allow 48 hours trend to assess the viability. Guide when ultrasound should note the intrauterine pregnancy and help assess the risk of ectopic pregnancy. So I think better to go with this one, right? From here or not. Still you are not going with that. What is your answer? Yes, yes. Yeah. Okay, so next question. You can see, right? This is repeated question. If you have done this in September, you will repeat the same question, right? Not the same, but kind of same, because in November we got the same kind of question. That's why I have added this one, right? Yeah. Okay. That is the recall power, doctor. But you have to remember, okay, the main thing in exam week recalls. So, like, we are getting all the topics during that week, and we just read, and we have like a fresh memory, right? The other things in recall, you have practice, and you still know, but sometimes you need to make sure, like, you have to revise it more, right? Yeah. Okay. So the next one. A 4-week old baby vomiting started around 2 weeks ago. After every feed, it's become forceful. Mother is anxious on examination. Growth 50th centile. Abdomen normal. Next best step, ultrasound. Reassure the mother. Esophageal pH monitoring. What do you think? Type your answers in the chat. And, what do you think, doctors? Hurry up and answer. And diagnose this. Okay, diagnose this one. What is this? What do you think? Mm-hmm. Today I'm thinking, doctor, doing like a few more hours. What do you think? And cancel the free theory session and do free theory session like extra days in next week, because we have to cover this file. What do you think? Like at least 1 hour? What do you think? Or you need a break? It's up to you, anything. What do you think, doctors? Or you need a break? It's fine. Anything. Okay, what about other doctors? Hurry up, hurry up. It's fine. Anything, anything. I'm okay. We can keep weekend now extra. I didn't get Dr. Ritik, but we can keep weekend now extra. What is it? I don't get Dr. Ritik. Can you tell me? You are telling, okay? What you are telling? I don't get it actually.
He meant like we can keep the weekend
Okay.
free so that you can do the extra hours now.
Okay, yeah, that's what I also thinking because we need to at least cover some topics, right? I can do the free theory sessions later dates. So we don't have much, okay? I just want you to like finish at least today's file. Okay, so you have diagnosed this as what? What is this, doctor? This is parodic stenosis, right? So give me 1 minute, doctor. I have to send a message in the group. So during that time, please read this one and type your answers. Okay, I'm typing the message because I have to inform them, right? Okay, so what do you think? Mm-hmm. So you have 1 minute. There are so much scammers in the group. I don't know, they need like 2 to 3 person for remote job. I don't know what else they are talking about. Even I don't understand. Okay, here 6-week-old boy present to the emergency department with his parents due to frequent vomiting over past week. The vomiting is described as forceful and projectile, occurring after most feeds. The vomitus is non-bilious and he was born at the term with no complication and has been growing well until this week. He has no significant medication at history and take no regular medications. Examination appears slightly dehydrated but alert. Pulse rate 150, BP 100, BP 80 by 50, respiratory rate 40, and temperature 36.8. And his abdomen is soft and non-tender. No masses are palpable. Visible peristaltic waves are noted in the epigastrium. So you all going with abdominal ultrasound. So let's check why. In this case, the classic picture of pyloric stenosis, which typically affect the male infant around 3 to 6 weeks of age, right? And I want to ask, do you remember? I have told you a simple trick for pyloric stenosis, like in measles, like three C's for scarlet, four S for here. What is this? Do you remember? I have teach you about what three P's, right? Three P's. What peristaltis? Sorry, peristalsis is visible. Then another P, projectile vomiting, right? Projectile, or in some cases they are giving a forceful vomiting. Then the next one is palpable mass. In here, we can feel olive shaped mass, right? But not in every case. So please remember, okay, palpable mass is not can see in every case. So here, abdominal ultrasound is diagnostic test for choice of pyloric stenosis. And it can directly visualize the hypertrophic pyloric muscle and measure the thickness and length. The diagnostic criteria typically include pyloric muscle thickness greater than 3 to 4 millimeter and pyloric channel length greater than 14 to 18 millimeter. Ultrasound is non-invasive, does not involve radiation, and has high sensitivity and specificity for this condition. Okay, so ultrasound is the uh, investigation of choice. Here also the same thing. This is from RCH guideline. Here also you should know between 2 to 6 weeks is the typical age, and this patient is having non-bilious vomiting, right? So tell me example for bilious vomiting. Bilious vomiting example in pediatric. So what are the bilious vomiting example? Give me one example. Give me one example. Yeah, it's a duodenal atresia, right? So duodenal atresia, you can remember it has three D's. Okay, three D's. Why? Usually this is not the topic. Okay, I'm just telling because then it's easy. Usually duodenal atresia occur in day one of life. So 1D is day one. Then we can see the double bubble sign in X-ray, right? The double bubble sign. Okay, I'll show it. This is an extra thing, okay? Because recently I haven't seen this duodenal atresia question. Here you can see the double bubble sign. Here one bubble, two bubble, double bubble sign. Okay, remember like that, the double bubble sign. Mhm. Then what is the third D? Third D, this is associated with Down syndrome. So please remember these three Ds, okay? Yeah, three Ds. Yeah. Yeah. So remember that one. This is not the topic. So pyloric stenosis, it's usually 2 to 6 week children and male predominance. And usually risk factors are firstborn and parental history of pyloric stenosis, preterm birth, younger maternal age, postnatal exposure to macrolide antibiotics, formula feeding, maternal smoking during the pregnancy. So I have read this part because in the question in the STEM they can give these risk factors as well. Okay. And history, vomiting. Vomiting is non-bilious and blood stain in the less than 10%, and infant may appear hunger post vomiting. So please remember this one, okay? Hunger post vomiting. Hunger post vomiting. Then what else? You should remember here. And this is the projectile vomiting. We call it forceful vomiting as well. So remember those things. and weight loss or inadequate weight gain. So examination, we can see the dehydration in our, as in our case we discussed in the previous question in emergency one, weight and plot on growth charts with previous weights if available, visible gastric peristalsis. Okay, in our previous case also we can see the peristalsis and pyloric mass. Not in every case, some cases we have palpable olive mass located in the right upper quadrant at the lateral edge of rectus abdominis muscle. Best felt from the left side with the infant settle and supine. Then here it's unlikely to be present in early presentation. Okay, yeah, that's all. And what is the management? Here, in first investigation, capillary or venous blood gas electrolyte and glucose and abdominal ultrasound is a 95% sensitive diagnostic investigation for the these pyrocysteine. So what do you know about hypochloremic hypokalemic metabolic alkalosis is a complication from these prolonged projectile vomiting. So we remember this one because in some months they have asked about this one. Okay. Yeah. Then then yeah. So treatment is emergency case. We have to follow the ABC. So gain IV access, correct dehydration, stop oral feed, and fluid management. So this is the part A. Okay. Yeah. Okay. 1 minute. Okay. I have to take. Give me 1 minute, doctors. Okay. Still one is stuck. Okay, fine. So, in this question, so a married couple present for counseling, the wife is HBs antigen positive and HBe antigen negative. The husband is HBs antigen negative and has no documented history of hepatitis B vaccination. So, what is the most appropriate advice? What do you think? What do you think, doctors? What do you think? Type your answers in the chat. Mm-hmm. Okay. Okay, so tell me why he need vaccine. Explain me. Tell me. What is your opinion? Why? Why is that? Okay. Mm-hmm. Mm-hmm. Okay. Wife positive. Yes, no HIV. It's vaccination. Okay, yeah. Okay, I think we have done the same question in 1 minute. In okay. No, 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 not the same question, but it's fine. I'll explain from that on because I haven't added because we can read it from our PDF. 1 minute. I will add later, okay? Because I was editing, I search and I Okay. Minute. How to search from here, doctors? Okay. Do you remember these files we have discussed? These are old files. Yeah, what's that? Mhm. Okay, not this one, doctor. Sorry. Hepatitis B, come, hurry up. Day 1, part 3. Just 1 minute, doctors. I can't find which day. Oh, okay, the measles. Okay, part 3. Sometimes very hard to find in here, right? Same page 60. Okay, here. So, so what we can tell about these hepatitis serology. So in our case, let's interpret the wife. Wife is HBS antigen positive and HBE antigen negative. Okay, let's interpret it. Our wife is HBS antigen positive, right? And we don't know about anti-HBSO, anti-HBC and anti-HBS, right? We have no idea. So what about in anti-ABE? What we can see in that case here? Question they have mentioned HBS antigen positive and HBE antigen negative. So what does that mean? Tell me. What does mean, doctors? I'm just asking you to interpret this. We are like, mhm. HBE means the. Do you remember that I told you E? You can remember it as the infectious, right? Patient is infectious or not, right? In E, do you remember that day I told you? You can remember antigen E as E and I like going same. Usually we detect antigen E as a infectivity, right? Infectivity. So if the antigen is negative mean, HBE antigen negative mean, the infectivity is less, right? But uh, it does not exclude the infectivity. Just give it idea, infectivity is low. That's it. Okay. Not telling, not infective. And wife is HBS positive. HBS positive in which cases, doctors here? HBS antigen positive in acute case and chronic case, right? Acute case and chronic case. So we don't know yet if acute or chronic, but in HBE antigen negative means the less infectivity. This can be what? This can be a chronic case. Can be, okay? I'm not 100% telling you this can be due to interpreting these two parameters. Then the husband's HBS antigen negative. Okay, our husband's antigen is negative. So let's check antigen negative in which cases? Resolved hepatitis B, vaccinated patient or susceptible patients. Okay. So these are the three criteria for HBS negative and has no documented history of hepatitis B. So he is not vaccinated. So here the vaccinated patient is out. So it can be resolved hepatitis B or susceptible patient, right? Susceptible patient. Then here, what is the most appropriate advice? So in that case, patient is HBS negative and they haven't mentioned anything about the antibodies, right? The IgG antibodies, like good antibodies, right? Okay, not they haven't mentioned anything about his good antibodies like IgG. So in that case, better because this patient is susceptible for HBV virus. So in can be susceptible. So better we can vaccinate this patient, right? Okay. So you are correct. I want you to like explain from like interpret it one by one. Okay. And there's no history of hepatitis B. That means there's no history of hepatitis B. Mean this also can be out, right? So resolved hepatitis B also can be out. So the only thing is susceptible patient. So everything is negative. So in that case, we have to vaccinate these patients. So that is the best option from here. Vaccination, right? Good. So the next question. A capillary glucose screening test done on 2,100 people. 100 test positive and false positive rate is 1% and false negative rate is 20%. How many actual have the disease? So what do you think? So type your answers. It's okay to take some time. What do you think? What do you think, doctors? What do you think? Okay, let's calculate this together. Okay. Yeah, even I don't like stats. You, yeah, I hate stats. But don't worry, doctor. Like if you haven't complete or if you haven't studied statistics like this, the calculating part, it's fine. Okay, because but please go through from their studies like we have cohort study or different studies. So go through that. That's not hard if you have like if your exam is in next month or March, and if you haven't touched like these calculations part, so don't be upset. Okay, don't be upset. Just don't waste too much time on this, because I'm telling in the exam maximum you will get one or two questions maximum from calculation, one or two questions. And if you are doing exam in later days, you don't have to worry. This question is repeated, the same question repeated in during whole exam week. So better if you haven't touched anything, just don't take too much time to go through this statistic. Okay, just go through that studies like what are the cohorts and where can we see the prevalence, where can we check the incidence and incident like main definition you should know, right? Because some questions are asking about given a scenario, and but the calculation, don't worry, we are just getting like maximum two question, and this everything is repeated in the full week. Even I got this. Oh no, no, not this one. In November, I got exact same questions. Okay, exact same questions. I got some two questions. So both are exact same question. Do you remember that anxiety question, like 50% something related question? So I got exact same question. The like stat questions are not changing in previous year, but February, let's see like what is happening. Then we can get an idea. Okay, here. So they are asking how many actual have the disease. Okay, here. So I have added like step by step. So before that, mm, they have given what the criteria they have, because in the exam also we are not getting like much time to calculate and everything with that exam stress and everything. We don't have much time to calculate. So better if you can read the recall and go and mark, because it's just one question, right? Yeah. Don't take more than 1 minute to solve these questions. Okay, because it will affect the easy question, like the questions that you know. Okay, so please don't take more than one. Here, the capillary glucose, they are mentioning total people screen is 2100, and the test positive. Positive is 100. Okay, 100 test is positive. Then false positive rate is 1, and false 1%, and false negative. What is in the chat, doctor? In our chat, what is Dr. Ritik? I just saw your message. Sorry for that. What is in the chat? It's not loading also. It's something related to. If you are sending something, doctors, please tell me, because while I'm doing the class, I'm not able to check the hepatitis question. Oh, thank you so much, doctor. Yeah, yeah, this is the question. Yeah, doctor. Yeah, yeah, that's the question. Okay. Yeah, thank you so much. You are like a life saviors most of the time, doctor. Thank you so much for that. Yeah. Okay, and they are asking here how many actual have the disease. So here we have to use false positive raised on non-disease. So we know when we are using false positive and false negative. So false positive in non-disease, right? If there is a false positive mean, that we use in non-diseased people, right? And false negative use in diseased people, right? So there is a bunch of diseased people, and some people are getting a negative result, and but still they are diseased. So that's called false negatives. And there's a bunch of patients, bunch of people without having any disease, and some of getting some positive, but after checking everything they are false positive. So we use false positivity in non-disease and false negativity in diseased people, right? So you know now when we use false positive and false negative. And they have given false positive rate as 1% and false negative rate 20%. So false positive mean, so non-diseased people, there is a non-diseased people. So 1% mean non-diseased people 99, and false positive 1 people, right? As example, this I am telling. So false negative in diseased people, that mean 80% are positive in this disease, and 20% have false negative, right? Like that they are mentioning here. So hope you understand those part, right? Then step one, false positive. So let's go through this false positive. Here, false positive rate is 1% of people who do not have the disease, so non-diseased people. 1%. So number of who actually have the disease, we can take it as X, right? Then people without disease, because total is 2100, and number of who actually have the disease. They are asking who actually have disease. We can take it as X and 2100 minus X, right? Okay, so we have to find this X. Then then people without disease, okay? Then false positive is 1%. So false positive is 1% and that equal then people without disease. So without disease is 200. Sorry, 2100 minus X, right? So 1% of 1% from these without disease, so non-disease people. So that mean 1% mean 1 divided by 100 multiplied by 2000, sorry, 100 minus X. So that is 0.01 multiplied by 2100 minus X. So we have a one calculation. Then we have true positives and they have given false negative rate as 20% and so the true positive rate is 80%, right? Here overall they have got 20% and so true positive is, so true positive is 0.8 multiplied by number of who actually have the disease, right? Because this is a percentage. So in that case, 0.8, it's right. So we have two calculations. Then we can use the total positive test. Total positive test means true positive plus false positive all, right? That means C true positive test mean 100, right? Here in the question they have given it as 100 positive. So true positive is 100 and we have true positives and false positives. So here false positive is 0.01 multiplied by 2100 minus X. So we have to add that one and plus false positive. So here, 1 minute. No, true positive 0.8 X and false positive is 0.01 minus by 2100 minus X. So all together 100. Then we have to do the calculation. So if you can calculate this 0.79X equal to 79, then that means X is 100. Hope you understand it, doctors. So you should know in here the total positive test mean true positive and false positive. Okay. Then true positive is 0.8. Here false positive is 0.01 multiplied by 2100 minus X. So all together is 100. So we have to do the calculation here. I know, but please listen this again, then you will understand. It's not like very hard. You should know what are these terms. You should know when we should use false positive. So false positive mean among non-diseased people, right? And false negative among diseased people. That is the main thing first you should know, right? When these false negatives and false positive present. Okay. What about other doctors? Do you understand it? I don't know you understand or not. Please tell me how to do this in one. Yeah, that's the thing, doctor. That's why I'm telling you to like don't waste time. This is my personal opinion. Okay. So don't try to solve the questions because it will take much time because you have other questions like the theoretical question and you can easily answer if you're like stuck with this question and if you are taking like 2 to 3 minutes for this question and it's eventually reduce your overall time, right? So please like don't take much time and don't, this is just 1 or 2 marks, okay? So please remember. Yeah, doctor. But in most of the cases, I think some doctors are try to like solve this and write down these numbers. Then after the exam, they will remember these things and just send it in the send like that. Okay, so then most of the even in November, I got the exact same questions. So that's what I'm telling. Yeah, like in most of the years. Never see these questions. Yeah, even I don't like these that questions, doctor, because like it's very hard to like solve this in like 1 minute, and we have to think, right? And we have to do the calculation, and with the exam stress, anxiety, it's very hard to do the calculation even during that stressful situation, right? Yeah. Okay. So next question. But the theory behind it's not hard. Okay. So next one is ECG given QRS whitening. She took a white tablets from her aunt's bag for suicide. What is it? What is this drug? Digoxin, amitriptyline, lithium. So what do you think? What are the doctors? YB? Yes, are the doctors? Yes, Dr. Bhagya. Okay, what are the doctors? Dr. Mefta, you are silent today. Why? What is happening? I'm sleepy. Why you working, no traveling, no cooking? Mm-hmm. Why are you going with amitriptyline? Why? Give me the reason. Mm-hmm. Yeah. Fell asleep. You can't sleep during the lectures, doctor. Because then you have to revise it again, right? You have to watch the video again, right? Yeah. It's post lunch, yeah. Oh, post lunch is so hard to write. Yeah, that's normal. Okay, so here, what we can see in this case is QRS widening. So QRS widening is, yeah, more typical in TCA poisoning, right? So let's little bit go through this amitriptyline or TCA poisoning. Here, what are the clinical features that we can see in TCA poisoning? So we have CNS features, cardiovascular features, and anticholinergic features, right? So remember like CCA, CNS, CVS, anticholinergic effect. So what are the CNS changes that we can see? Sorry, seizures, consciousness problem, and CVS, hypertension, sinus tachycardia, arrhythmia. Okay, we can see. Then anticholinergic mydriasis, dry, warm skin, urinary retention, decreased bowel sound, delirium. So these are the features that we can see. Then let's go through the key investigation. Key investigation for TCA poisoning are ECG. ECG, blood gas analysis, and serum potassium concentration. So we have to check all of these, right? 1 minute. Yeah. Then, how we should treat these patients? How we should treat these patients? And what are the key features we can see in ECG? They have no. What we can see in this ECG? We can see the QRS widening, right? More than 100 millisecond, right? More than 100 millisecond. If it is more than 100 millisecond, risk of seizures. If it is more than 160 millisecond, increased risk of arrhythmias, right? So remember those things. Then what else? And QT prolongation also can be seen. Then, mm, yeah, those are the things we have to remember. Doctors, give me 1 minute. Okay, then how we should treat these patients? This is a poisoning, right? We have to follow the ABC pathway, right? Airway breathing. Intubate and ventilate the patients following TCA ingestion of more than 20 milligrams per kilograms, or patients who have decreasing level of consciousness, seizures, or cardiovascular toxicity. If indicated, early intubation and ventilation is important, ideally within 2 hours after the estimated ingestion time. Okay, estimated ingestion time. I have a question. I have e-medicine questions in my notes. I'll add these as well. Then you will get an idea, like how we manage, like that. Okay. Yes. Then what else? Here it is recommended to hand ventilate the patient during the induction of anesthesia for intubation. To avoid apnea and reduce the risk of burst in acidosis, also consider of giving sodium bicarbonate. So sodium bicarbonate, okay? Remember that one as well. Then what about circulation? Treatment for hypertension. For hypertension due to TCA poisoning, first line treatment is intravenous fluid resuscitation. In hypertension persistent, start inotropic support with noradrenaline. Then treatment for QRS widening. So what we can do for the QRS widening? Okay, I'm just adding the question. Just give me doctors 1 minute. Okay, done. So here, QRS widening, progressive and associated with airway breathing or circulatory compromise like arrhythmia, hypertension, or CNS depression, immediately starts serum alkalinization, intravenous sodium bicarbonate, and concurrent hyperventilation therapy. For serum alkaline, this adults and children use sodium bicarbonate 8.4%, 1 to 2 milliliters per kilogram up to 100 milliliter. Intravenously every 3 to 5 minutes and titrated a narrowing of the QRS complex and aiming for the serum pH between 7.45 to 7.55. Maximum dose is 6 milliliters per kilogram. Plus hyperventilation by intubation and mechanical ventilation aiming for serum pH between 7.45 to 7.55. And here serum alkalinization can cause hypokalemia due to intracellular potassium shift. Monitor the serum potassium concentration and replace the potassium if required. Then treatment for the arrhythmias. So basically we are giving sodium bicarbonate is the antiarrhythmic drug choice patient with TCA poisoning, right? Yeah. What about decontamination? For TCA ingestion, for more than 5 milligrams per kilograms of a uh, gastrointestinal decontamination with active charcoal to alert and cooperative patients who are able to protect the airway and present within 2 hours after the estimated and estimated ingestion time. The patient is intubated. Activate charcoal can be given any time after ingestion via NGO or gastric tube to confirm correct placement of NG tube. Then seizure control is a self-limiting usually, and if it is not, treat with benzodiazepine. Yeah. Then what is the TCA poisoning follow-up and observation? Admit symptomatic patient with TCA poisoning. Oh shit. Hello, doctors. Oh, hello, doctors. Can you hear me? Like, thank God. I don't know when. Can you hear me, right?
Yes, doctor.
Yeah, okay. Thank you. Suddenly there was a power cut and I don't know. That's the I hate here because like most of the time if there's a power cut or something like that. Okay, so hope thankfully I have connected again. Yeah. So where was I? No, no, it's fine, doctor. I want to finish this file. Yeah, okay, we will do one more this question and we will finish. I know you also exhausted. Yeah. Okay, so what about the follow-up? Admit symptomatic patient with TCA poisoning for observation. Most severe toxicity due to TCA occurs in first 6 hours after ingestion. Admit patient with severe TCA poisoning to intensive care and discharge patient if they remain asymptomatic for at least 6 hours after ingestion. Sedative drugs can continue to cause significant cognitive impairment for several days following exposure. Advise patients not to drive or operate machinery for least 3 days after discharge. Okay, this is the question. So, a 32-year-old woman present to the emergency department after being found unconscious by her housemate. Emptying packets diazepam amitriptyline were found nearby. The exact time and dose of injection is unknown. She has history of depression and anxiety. On examination, she appears drowsy with GCS score is 9. Her pulse rate 110, blood pressure 100 by 60 and respiratory rate 6. SpO2 90% on the room air and temperature is 36.5. Her pupils are 4 millimeter and reactive. ECG shows sinus tachycardia and QRS duration of 100 milliseconds. So the answers are they are asking which one of the following is most appropriate next step in management. So I'm telling the answers. First one intubation and ventilation, gastric lavage, administer flumazenil, administer sodium bicarbonate, administer active charcoal. So what do you think? What should be the answer? Yeah, it should be intubation, right? So here. Intubation and ventilation. Why? The patient present with decreased consciousness and respiratory depression due to mixed overdose of benzodiazepine and TCA antidepressant. The priority in managing any overdose is ensuring airway. So intubation and ventilation is the most appropriate next step given in GCS, CO, and respiratory depression, right? This will secure the airway and prevent aspiration while allowing the supportive care. Yeah. So, so we will stop from now, right, doctor? It's almost 4 hours, and we will continue from. I know you were also very tired, right? Yeah, even you have a coming exam, right? So it's fine if we We in next day also we will do more like 30 minutes, then we can finish the file. So thank you so much, doctors. Yeah. Do you have any questions or anything you can just ask? Yeah. Thank you so much, doctor. Dr. Rabab, I remember your question when it is urgent case. What about this antiplatelet therapy? Um, I tried to find, but I couldn't find anything. But I think there was some question related to this in handbook, as I remember. But I'll find something and add here. Okay. Thank you so much, doctors. Yeah, and we will meet on Monday. You have 2 days, and please revise, 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 because now I think you can feel like when we consider the November exam. Can you feel how much topics are repeated in November exam? The topics, not exact question, right? Yeah, that's what I'm telling. Do recalls, then you will have the bunch of topics and you know what kind of questions that can, as example, hepatitis B. They have asked those kind of question in September, and if you identify how to interpret it according to that table, the TG table, then you will easily understand it and question, and you can answer it in the November exam. That's how you should use the recall with that theory, right? Yeah, and thank you so much, doctors. We will meet on Monday and have a good weekend. We'll meet on Monday, right? Okay, bye bye. Okay, I'm gonna stop the session. Okay, so bye bye.